Good evening, everybody. I would like to warmly welcome everybody to this very interesting ESGE webinar on early colorectal cancers on this evening of Wednesday, 10th of April. I'm Leo Moons, a gastroenterologist in the UMC Utrecht, and I have a special interest in early colorectal cancers. And maybe like you, I am very interested to hear all the new insights on the treatment and risk stratification. To my opinion, early colorectal cancers is a very exciting topic. We encounter them much more often, of course, due to the introduction of bowel cancer screening programs. And I think the way we are approaching these cancers is rapidly shifting. And a lot of new approaches and techniques are being developed. Tonight, we have two excellent speakers. The first will be Professor Andrea Tannapfel. She is pathologist at the Institute of Pathology at the Ruhr University in Bochum, in Germany. And she will go into depth on the histological risk assessment of locally excised T1 colorectal cancers. And she will be followed by Barbara Bastiaansen, a gastroenterologist at the Amsterdam UMC in the Netherlands, who takes you into the changing world of local excisions. Before we start, we just have a few housekeeping announcements. We have decided to have a panel discussion at the end of all the two presentations. So please put all your questions in the Q&A, and hopefully we can discuss them during the panel discussion at the end of the presentations. If the enthusiasm is overwhelming, we have to make a selection, so I apologize for that. But we try to answer all the questions during the presentations. So now I want to invite Andrea to start her presentation and to introduce us to the developments of histological risk stratification.
Yeah, thank you, Leon. The organizers, thank you for the opportunity to present some histopathological data concerning the risk factors for lymph node metastasis and early colon cancer. I have nothing to declare, and I think the problem is clear. We have early colon cancer, and you can go for endoscopy if the risk of lymph node metastasis is very low. And to ask the pathologist what he's doing, he's looking for the presenter, he's getting the presenter. What are the parameters assessed on tumor tissue to predict the probability of lymph node metastasis? You already know grading, tumor differentiation, how similar is the tumor in comparison to normal mucosa. We have lymphatic or vessel invasion, these small tumor cell emboli within a lymphatic vessel on its way to a lymph node. And we have, as a third parameter, the submucosa invasion, the depth of tumor invasion in the submucosa. And if you look to the literature, then there is most often written from lymphatic invasion, but also from venous or very, very rare from perineural invasion. And this is closer up. This is a lymphatic vessel with a tumor cell embolus in the submucosa fat. A new thing which is coming up, and it's in the German guidelines written, is the presence of tumor cell budding. What's the definition of budding? These are few tumor cells, undifferentiated tumor cells or isolated tumor cells at the invasion front of the tumor. The tumor invades the submucosa, and at the interface between submucosa fat tissue and tumor cells, there are tiny cell groups indicated here in red with immunohistochemistry, but you don't need immunohistochemistry. And these small tiny buds are tumor cell clusters, and the idea, the biological idea behind this is that these tumor cells are very aggressive because this is the interaction front between invasive tissue and tumor cells, and these aggressive tumor cells are going to the invasion, are invading vessels, and are a risk determinator of lymph node metastasis. And then you're just calculating these buds, grade 1, 2, and 3. And this new system is validated 10, 12 years ago. And these are studies from the very beginning of tumor cell budding indicating that a high grade of tumor budding, lots of small tiny cells invasion the submucosa, is a determinator of lymph node metastasis in multivariate analysis. The grading we used years ago third or fourth tail grading, G1, 2, 3, or 4. And this is then wrapped up to a two-tiled grading system, low grade and high grade. And the grading is performed according to the least differentiated tumor part. The biological reason is that the least differentiated tumor cells are determine the biological behavior. And nowadays, it's not the predominant component. The predominant component is under discussion, but until now, we are using the grading system from WHO 2018. The grading was performed according to the least differentiated component of the whole tumor. And these parameters were graded high risk, G3 or G4, or lymphatic venous invasion and budding, low risk tumors G1, G2 without lymphatic invasion. Coming to submucosa invasion, these are examples. This is muscularis propria. This is submucosa, and this is mucosa. The mucosa is inflamed. These are lymph follicles. And you can see the submucosa and the mucosa. And within the submucosa, there are blood vessels or lymphatic vessels. And the biological idea is that the deeper the invasion in the submucosa, this is the submucosa fat, the more lymphatic vessels are present. The number of lymphatic vessels is high variable between patients, and it's depending on the surrounding tissue. If you have inflammation or scars, then you have more lymphatic invasion in case of inflammation. In case of scars, in case of fibrosis, for example, if colitis ulcerosa or Crohn's disease, you have scars in the submucosa and the number of lymphatic vessels is decreased. And how to graduate the invasion in the submucosa? And these are the so-called Kikuchi levels. You get the submucosa and make upper part 1/3, the middle part, and the third next to the muscularis propria, and they say submucosa grade 1, 2, and 3. And the number of lymph node metastasis is increased as you go deeper to the submucosa. And this is somehow a problem, and this problem will be discussed today in the evening because these Kikuchi levels, SM1, SM2, SM3, here are the lymph node metastasis rates, are somehow difficult to assess because the submucosa is inter-individual different. And if you are in the colon ascendens, the submucosa is higher. You have more fat in the submucosa of the colon ascendens compared to the rectum. For pathologists, the measurements and the third 1, 2, and 3, the classifications are difficult because if you have a cauterization artificial between submucosa and muscularis propria, then it's very, very difficult to get measurements or to perform Kikuchi level grading. And if you look at large series, more than 60% of all surgical resected tumors, which are PT1 or PN0, have a depth of tumor infiltration within the submucosa more than 1,000 micrometer. So these 1,000 micrometer are somehow artificial. Another problem are pedunculated polyps, if you have these kind of adenomas, so it's very difficult to take measurements because the submucosa is sucked into the polyp head. So the classification rule is if you have a pedunculate polyp, an adenoma in a carcinoma in adenoma, you said PT1, SM1. This is a classification rule. One exemption is if the tumor, the adenocarcinoma, invaded the polyp stalk more than 3,000 micrometer. This is arbitrary. If you are looking for pedunculated polyps for adenocarcinomas in these kind of adenomas, then it's wishful for the pathologist that the endoscopist told the appearance to the pathologist. Next problem, at least for German pathologists, are the Haggard levels. Haggard levels from adenocarcinoma just here, level 0, until level 4 in the submucosa next to the muscularis propria. We have a problem because level 0 of Haggard is invasion of the mucosa. It's a so-called carcinoma in situ. And for Germans, it's we don't like these carcinoma in situ definitions, so we get rid of it in our classification systems. So level 0 from Haggard is a little bit questionable, at least for German pathologists. And we have the problem with sessile lesions. There, Haggard is not applicable. And if you have an adenoma with carcinoma with submucosa disruptions, the submucosal tissue is pulled in the stark. So it's very difficult to define level 1 and 2 if the submucosa is inflamed and tumor cells are in the polyp neck or in the stalk. So in Germany, the Haggard levels are not very much accepted. Next problem is a deep submucosal invasion. I told you we have SM1, 2, and 3. And the definition, what is deep submucosal invasion? Is it more than 1,000 micrometers, the border I told you? Or is it SM3 or SM2 and SM3? And in the literature, you have various definitions also in the studies. You have 1,000 micrometers, you have 3,000 micrometers, or you have a cutoff of 1,500 micrometers. And if you have here the picture, this is adenoma, here is carcinoma, this is carcinoma in the submucosa, and here is the border between submucosa and muscularis propria, and this is a SM3 carcinoma of the submucosa. And there's a meta-analysis published 2 years ago to evaluate the true predictive value of submucosa invasion. And more than 20,000 patients, 67 studies. The average number of lymph node metastases, 11.2%. This is okay. These are all surgical studies with oncological surgery. And deep submucosa invasion has a, let's say, low predictive value, an absolute risk of 2.6%. And in multivariate analysis, the deep submucosa invasion is not a significant predictor. So let's say a little bit disappointing, and this is a cartoon of the study. They said, okay, submucosal invasion should be remarked, but be aware it's not an independent risk factor for lymph node metastasis. The same meta-analysis evaluated as tumor budding. I told you tumor budding as a very good predictor for lymph node metastasis. And a small surgical study published also 2 years ago, retrospectively performed in Sweden and Denmark, evaluating lymph node metastasis in T1 colorectal cancer And the only predictor of lymph node metastasis was lymphatic invasion, perineural invasion, and age of patients, especially younger patients, had higher risk of lymph node metastasis. And submucosa invasion in this study, SM1, 2, and 3, Kikuchi levels, has no significant influence of lymph node metastasis. What's new, for example, for TNM system, the TNM system is figuring out a new category. For example, PT1B. PT1 is submucosa invasion. And one suggestion is PT1B in the new TNM system defined as submucosa invasion depths more than 1,000 micrometer. These data are derived from several studies. One study is from Japan, depicted here. The authors said patients with T1B, deep submucosa invasion, defined more than 1,000 micrometer with no other risk factors, no lymphatic invasion, low grade. And these patients have lymph node metastasis from 0.8%, 3.8%, and the 5-year recurrence rate was very low. And in the multivariate analysis, only grading in this group of patients was independently associated with lymph node metastasis. So the authors conclude that PT1B, deep submucosa invasion patients without any other risk factors, without lymphatic invasion and low grade of grading, G1, G2, they said maybe there is no surgery needed because they have very low rate of 5-year recurrence, of very low rate of lymph node metastasis. If you are performing these PT1B ramification of T1 tumors, you have to have full solid walls dissections because you have to look for the submucosa and for the muscularis propria if you want to perform PT1B classification. Last point of my talk, what happens after endoscopic resection. This was also a meta-analysis 2 years ago. After endoscopic resection and surveillance, curatively endoscopic resection, you have a recurrence rate very low, to my opinion, 3.3%. The recurrence almost always occurs within 6 years and nearly 0% in low risk histology. And if you are looking for risk factors in the pathology working up, then first point is open question resection margins. We have in the literature various definitions of resected not curatively, R1. Are it defined as cancer within the cauterization margin, or is it 0.1 millimeter? Is it lesser than 1 millimeter or lesser than 2 millimeters? And in the German guidelines, it's written lesser than 1 millimeter, maybe a threshold. It was a study, if you have residual disease, 0.1 millimeter, 2.9% recurrence rate, and 1 millimeter, 0.6. So the 1 millimeter is somehow questionable. The next problem is if you are not able to assess the resection margin. Is it Rx? This is not good for tumor documentations. Is it an indication for surgery? If you have Rx or R1, residual cancer is shown up in 22%. This is a little bit higher, to my opinion. Old data, and in these studies, we did not examine budding, so maybe this could be better. And we have entirely no data concerning probability of lymph node metastasis in this situation. As there may be a little bit open questions. New parameters in histology risk assessment may be tumor stroma ratio. Tumor stroma ratio is correlating with tumor cell budding. If you have more desmoplastic reaction, you have these small tumor buds. If you're going deeper to the submucosa or muscularis propria, you have correlation with lymphatic invasion, and you have, of course, in correlation with tumor grading. But in T1 carcinoma, you have generally lesser stroma, though maybe this tumor stroma ratio may be not a very good parameter. Another suggestion for more accurate is more measurements extension. For example, the whole tumor extension with planimetry, or the invasion to get an idea. The submucosa is the area infiltrated, and to grade the area which is infiltrated, or just look at the tumor invasion front and get measurements of the tumor invasion front. Next hot story, at least in publications in the literature, is artificial intelligence. Just say the rapporteur to get off a number, a parameter of risk assessment. There are some few data concerning budding using artificial intelligence, but maybe in a webinar 2030, we have KI and lymph node prediction or molecular makeup, but not yet. Open question, and this is my last slide. What is deep submucosa invasive early colon cancer? A precise definition is still lacking. Maybe we could clarify the situation if we have a new category in the TNM system that everybody has to measure and has to get an idea. Is it PT1 and is it PT1A or B? We have no idea what are we going to do with RX or R1. Should we do endoscopy again? R1 for pathologies is a little bit difficult, because maybe if you have residual tumor, if you have a tumor at the resection margins, it's maybe infiltrating deeper into the muscularis propria. You have a PT2 tumor. And well, we need prospective studies to get a better definition of deep submucosal invasion. And I'm looking for the next presentation. Maybe we are seeing clearer if what you are doing with these early deep submucosal invasive tumors.
Thank you very much, Andrea, for this very enlighteningful presentation. As mentioned in the beginning, we explain all the questions for the at the end. There are also some questions coming in. So I now want to give the word to Barbara. Please start your presentation, and then we have the discussion at the end.
Thank you, Leon, for your kind introduction, and ESGE for the possibility to give you some information on new endoscopic resection techniques for early colorectal cancer. So these are my disclosures. So as you all know, national bowel cancer screening programs have increased the number of early colorectal cancers. So they have caused this complete change in stage distribution. So now the majority of all cancers that are detected at screening are early colorectal cancers. And as Andrea also mentioned, they overall have a relatively low risk of lymph node metastases of around 10–11%. So these are important lesions for us as endoscopists because they are suitable for potential local excision and cure concerning these low risk of lymph node metastases. So when does a local excision is enough, or when do we consider it enough for a T1 colorectal cancer? Of course, first of all, it needs to be a radical, complete one-piece resection with tumor-free resection margins. And then, as Andrea already pointed out, the tumor should not have any histological risk factors for lymph node metastasis, as deep submucosal invasion, lymphovascular invasion, poor tumor differentiation or intense tumor budding, of which deep submucosal invasion is the only factor that we can optically somehow assess. And if one of those criteria are not met, then usually most international guidelines direct us to oncologic surgery with lymphadenectomy. And we do that because of this principle that we believe that if there's a high risk of lymph node metastasis, by taking out these lymph node metastases, we may prevent distal cancer metastasis, distant metastasis. And I think we all recognize these dilemmas we face, I think most of us on every MDT. So is this patient really going to benefit from the additional oncologic surgery or not? Or is a local excision enough? What is the risk of surgery for these patients? And we should also consider the competing mortality, especially in older and frail patients, and also considering the fact that also oncologic surgery will not prevent cancer recurrence in all cases. And then, of course, a local excision has a risk you leave lymph node in situ. So it's always balancing those risks. And I think we all know, all recognize this, and we should remember that at least 80 to 90% is overtreated with surgery. I wanted to share this. I think it's an interesting article from the French group. It's an emulated target trial. It's not a randomized trial, but in an emulated target trial, observational data can be used to like a randomized trial. So these are topically resected high-risk T1 cancers matched in groups. So around 100 patients in both groups, surgery group or surveillance group after a local excision. And what it showed, it was a composite endpoint on cancer recurrence or death. And in both groups, there was no significant difference in outcome. So there was no significant difference in the rate of cancer recurrence or cancer-related death. And that's also this study from Japan, also from 2024, so quite recent, is showing the same. So it was a propensity score study, local excision followed by oncologic surgery, 400 patients, and local excision alone, the same, around 400 patients. And what the study shows is indeed after a local excision alone, of course, there is a higher risk of local regional recurrence. So either intramural, slightly higher, but also lymph node metastasis, slightly higher. But the risk of distant metastasis in both groups is relatively, well, it's almost the same. So there is a very small difference in cancer-specific survival in both groups. Also for rectal cancer, this has been studied in a large meta-analysis, and we see that the distant metastasis risk for local excision or completion TME actually is not different in both groups. So in the TME group, it's 5.6% versus 7.2% in the local excision group. And then also in this study from Korea, the same results were seen. So this is a propensity matched analysis, also rectal cancer patients. Of course, the local excision, in the local excision group, the local regional recurrence rate is higher as compared to TME surgery, but the distant recurrence rate is exactly the same. And what was also interesting is that in the local resection group, the number of salvage surgeries was 18%, so meaning that more than 80% of patients could be spared radical surgery with the same oncological outcomes on the long term. So this is what guidelines are directing us to. So we see a lesion that looks suspicious for T1 colorectal cancer. We make an optical assessment on the depth of invasion. And then if it looks superficially invasion, then we might aim for an unblocked EMR ESD. But if it looks deep submucosal invasive, then guidelines direct us to surgery. But the problem is that that I have doubt on the how accurate are we actually in estimating the depth of invasion. And that seems to be difficult. This is a recent paper from Yutaka Saito on the JNET classification system, which was assessed by both European endoscopists and Japanese endoscopists. And what you see is that the accuracy is actually is not good enough, especially not for estimating the depth of invasion. So there's a significant risk of both overstaging and understaging using an optical biopsy. I think Andrea already mentioned this. There's quite a number of studies already with good detailed histopathology showing that if the cancer has only deep submucosal invasion without any risk factors, then the risk of lymph node metastasis is really low and not above 3%. And indeed, in this meta-analysis that we could perform, Lieselotte Zwager, because we also collected individual patient data from both Asian as European centers. Indeed, deep submucosal invasion was not an independent risk factor for lymph node metastasis, and the absolute risk is low, 2.6%. And I think also an interesting finding in this study that a significant proportion of all deep submucosal invasive cancers actually do not have any other risk factors. So a great proportion of deep cancers could be cured endoscopically if we have ways to remove them safely and complete. So if we would be ready to waive or drop deep submucosal invasion as an indicator for surgery, then, and the rest of the risk factors we cannot optically assess, then it comes down to a radical local excision and then let histology guide us to further treatment. So what techniques do we have? Now, first of all, of course, unblock EMR, although results for EMR, so snare-based techniques, especially when the lesion gets larger than 15 millimeters, are really poor. So especially with a snare resection, I don't think you have enough control over resection margins. That we also was shown by several studies that the risk of an incomplete resection, even for lesions 15 millimeter or larger, is quite high. And I think we all recognize the video. You think you have everything. The snare slips over the mucosa while closing. You think you have it, but then you see this little piece is still there, and it's not good enough for cancer. And then we have, we all know, endoscopic submucosal dissection, ESD, beautiful technique where we can remove large lesions en bloc just by cutting in the lower third of the submucosa just above the muscle layer. And we also know the good things of ESD, perfect histology, and R0 resections really high for non-malignant lesions or lesions with superficial invasion, and then low recurrences rate, only 1%, delivers a potential cure for low-risk superficial T1s, and basically tumors any size can be resected by ESD. The problem with ESD for cancer is that when the cancer is deeper than expected, then we might run into problems. This is an example of a lesion in the sigmoid, LST, largely benign, but there's a small focus of cancer. We start ESD, and in the periphery, it's fine. There's a nice lift, but then once we get under the invasive front, you see a clear muscle retraction sign. So you triangular shape of the muscle into the lesion. ESD can be completed en bloc here, but then the histology comes back and you see there is an involved deep resection plane. And that's also what studies show, is that the R0 resection rate for the deep resection planes really drop in ESD, and it makes you wonder if the submucosal plane is good enough if the cancer turns out to be deeper. And the problem is that very often the cancer is deeper than expected. This is the ESD, this is the ESD experience from Japan, beautiful study, 1,800 lesions, prospective registry, most of them benign lesion or non-malignant lesions, only 15% were actually submucosal invasive cancers. But you see these ESDs are performed on suspicious superficial invasive lesions, but half of them turn out to be deeper, so T1B. And this is the European experience. This is a study published in Gut in 2022. And authors were analyzing non-curative resection, ESD resections for T1 colorectal cancers. So they analyzed 207 non-curative ESDs for T1 cancers. And when you look at the results of these over 200 cases, you see that at least 70% were indeed deep submucosal invasive lesions, and then the R0 resection rate drops to 35%. So also that's really not good enough for cancer. And this is a Dutch experience, 3 large ESD centers in the Netherlands. Leon was working on it too. And you see that if an ESD is being performed intentionally on a T1B lesions, that indeed the R0 resection rate is only 55%. So is a transmural resection for T1 colorectal cancer then necessary? Well, first of all, at least 50% of all T1 colorectal cancers are size 2 centimeters or less. So that's a good size for endoscopic full thickness resection, for example. And the point is that the vast majority, and I think also Andrea mentioned that the vast majority of T1 colorectal cancers are deep mucosal invasive cancers. Then we have endoscopic full thickness resection, and that's I think all know the technique by now, and there was also an ESGE webinar on endoscopic full thickness resection, so I won't try not to repeat a lot from that other webinar, but it's an open-scope system, and if we are following the right sequence of steps, then the perforation is closed before we actually make it, and that avoids, of course, the risk of fecal spill. Many of the results have been shared on the previous ESGE webinar. So this is an example for T1 cancer in the ascending colon. It's a clear depressed lesion with a irregular pit and vascular pattern, QDO5. This is clearly a deeper submucosal invasive cancer. We start with marking quite tight around the lesion, unlike ESD. And the markings help because with the FTRD system, it takes away some light, so more difficult to recognize the target lesion. So the markings might help. And then the grasper is opened outside the cap, pushed to the lesion. And then we need to take some distance to allow wall duplication into the cap. You usually don't start with suction immediately to avoid the theoretical risk of entrapping other organs like small bowels or ureters. Doesn't happen in the registry, but that's always something we are training on. So then all markings are in now, and then the clip is being released. By turning the hand wheel, white ring is being pushed forward and the tissue is being resected. And then we check on a third entry of the endoscopy to check on the resection site. So the Dutch EFTR registry started quite early, also like the German registry in 2015, as soon as the device was available. And I think the difference in the Dutch registry is that our main indication is T1 colorectal cancer. So either a primary resection for a suspected lesion or a secondary resection after previous incomplete resection of a low-risk T1 CRC. But I think it's nice, these are new data to share with you on the primary resection for a suspected T1 colorectal cancer. And these are nearly 560 cases. And we are dividing them into low risk, and that is including deep submucosal invasion as risk factor, as only risk factor, because deep submucosal invasion is dropped as risk factor in the Dutch guideline, high risk, so one of the other risk factors. So as I said, 559 cases, slightly more male patients, 80% colon, 20%, almost 18% rectum, medium size of the lesion, 16 millimeters, and the specimen nearly 3 centimeters. Microscopic radically, so technical success 90%. And then if we look at the results, we see that indeed the majority of cases were indeed cancers, more than 80%, 82%. The majority indeed deep submucosal invasive lesions, 47%. And then if we first of all look at R0 resection, we see that the R0 resection for both superficial and deeper submucosal invasive T1 cancers is high, 91% for the superficial and 88% for the deep submucosal invasive lesions. And then if we divide them, so we focus on the T1 colorectal cancers, 346 cases, half of them low risk. And remember that the majority have deep submucosal invasion as a sole risk factor. High risk group, 47%. So in the low risk group, including these deep invasive cancers, in the early years, patients did undergo surgery, for example, for an SM3 lesions without any other risk factor, but in the surgical specimen, none of them had residual cancer. And in this selected high-risk group, so patient that did undergo completion surgery, half of them, there was a residual cancer risk of 16%. Most of them are lymph node metastases and 1% endoluminal recurrences. Now we have follow-up of 44 months. And so we focus on only the patients of which we have at least one follow-up a moment, so 272 patients. And then if we look at the difference in groups, so low-risk surveillance, there was one case of a recurrence that could not be cured. So we know that also from literature, of course, that even in low-risk cancers, there are some cases that are lost. It's just the biology of the tumor. And then in the high-risk surveillance group, there were 3 recurrences, so 5%, and 2 of them were local regional recurrences that could be treated by just salvage surgery. And in the completion surgery group, I can't see my screen. It's 6, well, they were in the same 6% of trying to get this, of recurrences, and none of them, well, they were all distant recurrences, so none of them could be cured. So to summarize EFTR for T1 colorectal cancer, of course, it delivers optimal histology because it includes the proper muscle layer, and that leads to complete histological risk assessment in almost all cases. EFTR has shown favorable R0 resections even for deep invasive lesions, 88%, with a low cancer recurrence rate of 1% also for deep invasive lesions with a follow-up of nearly 3.5 years. So it really expands our endoscopic treatment options in T1 colorectal cancer. For the rectum, EFTR is maybe not the best technique. For the rectum, we now have endoscopic intermuscular dissection. Is only possible in the rectum, where the muscle layer is so well developed, we can really differentiate the inner circular muscle layer from the outer longitudinal muscle layer. It's just an adaptation to the well-known ESGE technique, first described by Rani on severe fibrotic lesions, not on cancers. So what we usually do is just start with ESGE. We work to the muscle layer, and once we have exposed the inner circular muscle layer, we perform a selective myotomy of the inner circular muscle, exposing the longitudinal muscle fibers, and then by expanding the intermuscular space, we can perform intermuscular dissection, and we try to have the full inner muscle underneath the invasive front. Potential benefits from the intermuscular plane is that it might avoid complications that are associated with full thickness stemothermis that is usually performed on deep invasive rectal cancers like pelvic sepsis or peritoneal entry, by preserving the wall integrity of the rectum, and that also preserves potentially the plane for future TME surgery, especially in areas where there's very little mesorectal fat, bare rectal areas. where a full thickness resection can cause a lot of fibrosis, and it might minimize the risk of cancer cells seeding into the mesorectum. There's some proof on that this was a meta-analysis showing slightly higher risk of cancer recurrence after full thickness resections compared to endoscopic resection, but the conclusion of the authors was we cannot make a valid conclusion because we need more studies. Also, surgeons are interested in the intermuscular plane now and are really proctoring TAMIS surgeons in finding the intermuscular plane for all the potential benefits. So this is a video just quickly showing clearly a deep invasive lesion. So start with the ESD, work to the muscle, and as soon as the muscle is exposed, here a selective inner circular myotomy is performed. Very careful dissection just underneath the circular muscle, and then we expand the intermuscular space a little bit. You see nicely all the layers, and by expanding the intermuscular space, then the intermuscular dissection is performed, and that delivers this histology where you see that the tumor is really very close to the muscle layer. So you can imagine that ESD would not have resulted in an R0 resection of the deep plane. And here's a nice example with Desmin staining that you see how the tumor is really pushing to the muscle. So these are the first results published in 2022 from Utrecht, Leon, and Amsterdam. These are our first 67 cases, including our learning curve, so including the first case. And it led to technical success rates high, 96%, and R0 resection rates for deep cancers, 90%. And then we continued, and Lisa van der Schee, one of the PhD fellows of Leon, presented the results on UEG last year. So these were 140 cases now for suspected deep submucosal invasive rectal cancer. Indeed, as you can see, the majority, more than 80%, are indeed deep rectal cancers, 53% deep T1, technical success rates high, and R0 rate for the deep invasive T1 cancers, 93%. Of course, it drops when the tumor turns out to be deeper than the superficial muscle layer to 51%. Then if we look at the rectal preservation rate in this group of T1 deep cancers, we see that 76% of all patients had a rectal preservative, followed a rectal preservative strategy. And then if you look at the cancer recurrence at 17 months, we see that the cancer recurrence actually is relatively low, in the deep T1 group. Overall, in the deep T1 or the T2 group, we have 4 recurrences, 3 of them in the rectal preservation group, and all 3 were local regional recurrences, so could be salvaged by delayed TME surgery. And there was 1 recurrence in the completion surgery group, and that was a distal recurrence that could not be cured. So this is the latest update, but I think I should maybe skip it because of time reasons. But what was interesting is that indeed now we have 100. We focus on the deep T1 cancers with follow-up, and you see indeed that there are recurrences, of course, if we don't operate on high-risk T1 rectal cancers, 13% recurrences, 4 recurrences in total, but all were local regional recurrences and could be cured with a delayed TME. Adverse events are mild, only some pain, paracetamol use, so mainly grade 1, and patients are recovered very quickly after EID. The majority within 3 days, and almost all patients are fully recovered within 1 week. Also, functional outcomes seem to be favorable for EID. So Sander Albers was performing surveys on all patients that underwent EID, and major LARS is relatively low, only 6%, which is of course lower than in the group that had TME surgery. this is the situation in Holland now, where we have now over 300 EID performed in now 5 centers in the Netherlands. We're performing a prospective study with the primary objective of 3- and 5-year cancer recurrence. It's the ICON study. Yeah, so we will have more data in the near future. So in conclusion, my last slides. So the majority of T1 colorectal cancers are indeed deeper submucosal invasive cancers. The submucosal plane might, for these deeper cancers, seems to be not good enough, but EFTR and EID are nice new endoscopic tools that really expand our endoscopic treatment options and allow organ preservation in a large proportion of patients with also a very low risk of cancer recurrence during intermediate follow-up. It delivers accurate histopathology, of course, and the role of EID may be even further expanded by adjuvant chemoradiation. But also, if you look at the results from both EFTR and EID data, I think even for higher risk T1 cancers, active surveillance and early salvage treatment might be a valuable option for the future. And to wrap up, I think by treating those lesions can only be done when there is a collaborative spirit between endoscopy surgeons and pathologists, and all those lesions, of course, need to be discussed in MDT. Thank you very much for your attention, and I look forward to the discussion.
Thank you so much, Barbara. I hope that Andrea can join us so we can start the panel discussion. I think there are a lot of questions already came in. And maybe I want to start with Andrea. There was also a question on the inter-observer variability between pathologists. And I think that also, because we are normally as a gastroenterologist are considered to take the pathology report as a black and white report, it's present or absent. But there's, of course, a lot of debate. What's your opinion about whether we should be a central revision or an expert pathologist? What's your opinion about that?
Well, concerning budding, I think the question was concerning budding. It's relatively good, the inter and intra observer variability. You don't need any immunohistochemistry. It's just one diagnosis. You are looking at the invasive front, looking of the tumor, and then you can perform this 3-tailed body classification. And well, it's not a learning curve. It's absent or not. And if it's present, then you are looking how many you are counting, and then you are doing the job. It's not like Barrett dysplasia or DALM or ALM. Yeah.
But I also learned that there are some new reports coming up that there are some kind of pseudo-budding, which can exist in the presence of inflammation. So that might be an overestimation of the BD2 situation. I think that might be a severe problem, and that every pathologist is able to discriminate between them.
But not every gastroenterologist is able to perform full thickness or stuff like this. I think it's a parameter which is easy to assess, which is already present. You don't need any immunohistochemistry. It's like lymphatic invasion. You see it, you get it, and it's okay.
But there is also a reported inter-observer variability for lymphovascular invasion as well between pathologists. The kappa is only about 0.34.
Yeah, it's these studies are somehow bashing pathology studies. I don't think that it's necessary to get a referral center for these. If you are an expert in gastroenterology and endoscopy, then you have a good pathologist. And I think, well, you are learning with each other in this team, with spirit, Barbara says.
Okay, also a question for you, Barbara, because there was a question, if we know that distant metastasis, the depth of invasion is not so important, why not should we go for piecemeal EMR? Just get it out, unblock. And if you don't see any tumor budding or lymphovascular invasion, well, you're finished.
Well, I don't think that's the way to go, because first of all, if you have a deeper submucosal invasion, invasive lesion, then the submucosal plane is not good enough, and for sure not EMR, where you are more superficial in the submucosal plane. And also we really know, and I think Andrea knows that very well, is that you really make histopathologic analysis of all important risk factors very difficult because of cauterization and fragmentation. So I think you mess it up with the piecemeal EMR.
What do you think, Andrea? Is it indeed possible to have a good risk stratification on a piecemeal resected lesion of cancer?
While it's always discussed in MDTs, I think it's much more difficult to do with 10 pieces of bloody, coagulated, fragmented, necrotic. Okay, yeah. I will stop.
No, I can imagine that indeed the risk stratification is more unreliable in those cases. So
absolute, yeah.
I think there's a broad consensus that we should go for an unblocked excision to have optimal histological assessment. Yeah.
Of course, and pinned up with needles on a cork plate. It's very comfortable for pathologists to measure then and to get a valid diagnosis.
Yeah. And then come back to you, Barbara, because the problem is, of course, if we accept that we should remove deeply submucosal invasive lesions as a significant part of them might only show deep submucosal invasion, then of course it's difficult how to select those cases. What should we do? Should we use endoscopic ultrasound? Should we use MRI or other kind of imaging? What's your idea about that?
Yeah. I first of all, I think that we now have quite enough evidence to say that we should drop deep submucosal invasion as an indicator for oncologic surgery. I think I showed you the prospective series, the meta-analysis, and also, well, the data on EFTR and EID, I think, are really pushing us to that if we find indeed ways to remove those lesions safely and complete, then we should go for it. So it's like a diagnostic excision that. And how do you select those? Well, what I think is for the colon, EFTR is the way to go, and then we are limited by size, so that's 2 centimeters. You really see that the R0 rates are dropping after 2 centimeters. Also, of course, depending on mobility, and but I think 2 centimeters is a good cutoff. For the rectum, now that we have, of course, several options like TAMIS surgery, TAMIS local excisions, and now EID, where size is not as important, of course. Although the majority of lesions, if you look at the average lesion size in the EID series is 25 millimeters of lesions. So the T1 cancers are usually not that big, or you have a small focus in a larger lesion. So the thing is, what do we do with larger lesions in the colon with a small unifocal part of cancer that looks deeper than superficial? Should we start ESD on those lesions? I think that the data there showing that really the risk or the chance of getting an R0 resection in deep plane is not good enough. So what other options do we have then? I think one option could be hybrid EMR EFTR for the small invasive part, but can also be difficult because the invasive part should really be well demarcated, and you cannot come too close to it. And of course, we need data on that. There's only a small case series of 10 patients, I think, we published, but we need more data on that. But could be a valuable options. And the other option that is now out there, and the Dutch group is also looking at that, is laparoscopic wedge resections for larger than 2 centimeter lesions that can still be resected with a local excision, but then surgically by a laparoscopic, endoscopically assisted laparoscopic wedge resection. But I think we also need more data on that. I think that's the options that we have. Yeah.
Is there a place for endoscopic ultrasound?
In the rectum? Only in the rectum it's possible, of course. Yeah. to be honest, I'm not I'm not a big believer on the additional value of EOS, because if I look at the specimen and you see sometimes the pushing borders or the desmoplastic reaction underneath the tumor, that gives also a lot of fibrosis and reaction. I'm really in doubt whether any imaging technique, MRI or EOS, could make that difference. Of course, there are studies out there that showing that in very experienced hands, you might more easily differentiate between a deep T1 or T2, but I'm hesitant.
But what is how do you select? Because if you see it tomorrow, how do you select them for local excision or not?
Yeah, so in the rectum, so what we, and you know very good, Leon, so what we take as, so first of all, we need MRI staging CT1/T2 on N0 below the sigmoid takeoff to allow for EID. And then there's also an interesting study that Lisa, under your guidance, performed, where we see that if that's based on Gina's Brown's criteria, that if you have a 1 millimeter proper muscle layer preservation on MRI, that it's easily trainable, and it has a very high accuracy of more than 80% to correctly select patients that can be that where an intermuscular dissection can be done, and then won't lead to a deep T2, for example. So that also seems to help us in selecting cases. Yeah.
Yeah. And also, there was also a question, of course, if we start removing those deep submucosal invasive lesions and we go into intensive follow-up, for example, instead of completion surgery, there are a lot of participants asking, how should we do the follow-up? How long and which modalities should we use? And I think there's not a lot of data out there giving their clear advices on how we do it. And I think there's a lot of variation between countries. So what's your opinion about that?
Yeah, so what we do in the Netherlands is that we for rectal lesions, we perform, for the first 2 years, we perform every half year MRI, CEA and endoscopy, and then of course at 12 months also a CT abdomen and thorax, and then in the 3 years thereafter yearly MRI and endoscopy, and half yearly CEA levels. And for the colon, it's different. We do CT every year and endoscopy also every year, and half yearly CEA levels.
Yeah. Hey, Andrea, as a pathologist, how do you appreciate this eagerness of the young gastroenterologists to remove deep submucosal invasive lesions? How do you look at it?
If you preserve the rectum, go for it. Well, the problem is, as discussed, the lymph node. If you don't remove lymph node metastasis, the question is still unsolved if lymph node metastasis do metastasize. Okay, this is a question. Maybe you should comment on MSE analyzers, microsatellite instability. If you have an instability tumor, then maybe chemotherapy is enough in the future. Well, the future is a mix between young endoscopists, old pathologists, and well, technically driven.
Yeah, I totally agree. I think you raise an important point that we don't know really whether the lymph node metastasis return as local regional recurrence or whether they are the offspring of distant metastasis. However, the studies Barbara showed are more pointing into the direction of a local regional recurrence instead of an incremental risk of distant metastasis. So I think that we are really awaiting prospective trials. And I think that there are those two cases from the EFTR study group and also on the intermuscular dissection are promising.
Well, it's a differentiation between T1 and T2. I think T2 cancer, lymph node metastasis, it's 25%, and this is a real risk, and these metastases may be metastasized further. Yeah.
for question for you both, Barbara and Andrea, there was also a question for people going even further, saying if you have a T2 without any risk factors, what should we do for completion surgery, or should we then consider them as well as a low risk condition which might be follow up instead of completion surgery?
I think that's a very interesting question, and I hope that the near future will give us answer to that question. And if you look at the cancer, if you look at histology, I love to see the histology together with our pathologists, and then you see a cancer that is really pushing the muscle, and then the next day without any other risk factors, and we accept that, and then the next day you see the same, and it slightly invades the muscle, same other biology, and then you really think, how can it make a difference? I think is the depth of invasion really determining that risk, or is it the other factors that are determining that risk? And I'm a believer that a T2 cancer without risk factors is also a very low risk cancer. That's what I believe. Of course, we need further proof, but of course, the chance that you have a T2 cancer without any other risk factors will be lower than T1. The deeper you go, the higher the risk you will have a risk factor. So for T1, 40-50% without any risk factors is really good. You can cure half with just a local excision, but for T2 it might drop to maybe 20% without risk factors. But with the additional treatments that are there for rectal cancer, I still think that a local excision also for T2 cancers can still be a good option, or definitely for the future. Yeah.
Okay, well, I'm running through the last questions which are remaining. One question for you, Barbara, comes from is, what is the proximal border when the intermuscular dissection becomes impossible? Can you comment on that? To perform an intermuscular dissection, how high?
Well, yeah. So it's very important that you really look detailed at the MRI. So it really, so the sigmoid takeoff is not a clear anatomical landmark. So the sigmoid takeoff, so we usually say below the sigmoid takeoff needs to be rectal cancer, but especially when the tumor is located on the ventral side, really also look at where the ventral peritoneal deflection is located, because that might differ from the sigmoid takeoff, and it needs to be I think where our limit is when it's the ventral peritoneal deflection, because then the risk of peritoneal entry is really high. Yeah, so and it gets a little bit more difficult higher up in the rectum.
Now, we clearly discussed that intensive follow-up might be an alternative strategy to completion surgery. There are some other suggestions made by the audience. One of them, of course, for rectal cancer, which is, of course, a lot of intention for now, of interest for, that is adjuvant chemoradiotherapy as a completion therapy. Yeah. And somebody also suggested that we might do sentinel node and then laparoscopic lymphadenectomy of the sentinel node to see whether the patient is, however, tumor positive or lymph node positive or lymph node negative. I see Andrea shaking her head, so she has a clear opinion on that. Can you please comment on that?
Sentinel, yeah, sorry, but sentinel lymph nodes and the perirectum, it's, well, for 50 years there were first studies, there are skipping nodes. It's not a good organ for sentinel strategies. Definitely not. Colon, not.
No, yeah. There was a recent meta-analysis showing that for T2, T2, but I think it's highly experimental. And T3, T4, it was not worthwhile doing sentinel nodes. So I think we have to await other studies. Okay.
Maybe it's chemotherapy.
Chemotherapy instead of
yeah.
Or adjuvant immunotherapy. Yeah, we can all kind of I think that I think
surveillance.
Yeah. And I think that should be I think we should consider there are more options than completion surgery, than the remaining and especially organ preservation is going. The demand of the patient for organ preservation, especially in the rectum, is also going up. So they need to be and I think we should also discuss those figures with our patients, because we as doctors are known more risk preventive. We are more defensive, like patients. They are more willing to accept some kind of risk to maintain function of their quality of life.
Yeah, definitely. There's also nice papers on that. Yeah.
Unfortunately, I think we could have gone on for hours and hours. We have to make an end of this this session. Thank you so much, Andrea and Barbara, for your excellent speech and talks. And you were provocative, and so hopefully everybody has food for thought. So we go to the end of the discussion. Yeah, and I think we cannot end by everybody inviting. Please come to the ESGE days, which are just within a few weeks in Berlin. And we've seen already that some nice presentations are going to be presented there. So please join us and join the discussion. I think it's also very important to notice that we have the ESGE Diamond Jubilee. So there are lots of events coming on, like the ESGE Academy and the General Award and the Jubilee webinar. So please look out for all kind of new events this very special year. The fellowship grants are also open for application, so especially would like to visit other hospitals to learn, please go to the open applications. And of course, join us by joining by membership, join the webinars, join all kind of efforts and all kind of community. I think that we can strengthen each other by discussing all these nice topics. Thank you so much for all your attention and the nice question. I want to thank the speakers and the organizing, like Gabriela and David. And then we ended by this. Thank you so much.